Now, what about putting tubes down their nose? Can you do it? Sure. And if you've actually seen someone who's gotten intubated nasally by someone who knows what they're doing, it's a very slick procedure. Now, before we can talk about who, let's briefly take a look at how. How you do it is just like putting down an NG tube. If you put down an NG tube, what do? You shove it down the back of their nose. It bounces off the bones in the back of their nose. If you're nice to them, you give them a glass of water, and what do you tell them? Swallow. Swallow! And as they swallow the water, you shove it down, it goes in, life's good, not a problem. When you nasally intubate, you do exactly the same thing, except you pop an endo tube down there. And you shove it down the back of their nose, and when it gets to the back of their throat, instead of saying swallow, you say breathe. And as they go, you go, shh. And you know what? In the adult population who's sitting up breathing, about 80% of the time, it's going to go in the right spot the first time. Cool. So therefore, if you talk to anesthesia or ER docs and say, who is it appropriate, as a rule, to nasally intubate anymore, they'll actually teach you not a whole lot of people. There is, though, one category of patient who still is kind of nice to nasally intubate, and that's this. COPDers are fabulous to nasally intubate. Why? Do they ever lay down flat? No. Sure, when? They're dead, good. And if they're dead, you're not going to nasally intubate them, but they're sitting bolt up on the bed, turnipole can't breathe, heaving air in and out. They suck this thing down like a piece of spaghetti. You know what? It's kind of a nice trick to keep somewhere in the back of your head. However, who would you not want to nasally intubate? The biggest category, as a rule, is kids. Now, anesthesia will teach you there's two kinds of intubations, and that's called crisis and fluff. Crisis is what we're talking about now, meaning I want a tube right now. Fluff means you're having your tonsils taken out. If you're having your tonsils taken out, anesthesia can intubate you upside down, backwards, standing on your head, and that's a beautiful thing. However, if you want a tube right now, don't go down a kid's nose. The reason being, number one, the mouth hole is bigger than the nose hole. Number two, think about it. If you put it down the mouth, you actually see where the tube's going to go. You have a much better chance of putting it in the right hole. Number three, anatomically, kids' vocal cords are very anterior, which means they're out here somewhere. So if you just shove a hose down their nose, it ain't going to go where you want it to go. Number four is kids in the back of their throats have amazing vascular structures called tonsils. And if you start blindly bouncing an endo tube off their tonsils, they bleed. And if you've ever seen kids bleed post-tonsillectomy, you know what a fun time that is. Why would you possibly do this? Therefore, as a rule, down a kid's nose is really not where it's at for an emergency tube placement. The other categories we'll talk more about later is this. If you have bruising around the eyes, what medical sign do we call this? Good, that's called raccoon eyes, just like you picture in a raccoon. If you see bruising around the eyes, you've got raccoon eyes. As we'll show you later, you've got a basilar skull fracture. You don't want to nasally intubate them. What do we call bruising behind the ear? It's called battle sign. Good. Just like you're going off to battle, if you have bruising behind the ear, you've got a basilar skull fracture. You don't want to nasally intubate them. What do we have coming out of the ear? It's blood, right? But it's blood potentially mixed with what? CSF. Good. It's cerebral spinal fluid. How do you tell if it's blood mixed with CSF? Well, actually, unfortunately, there is no good way. Up until recently, you're correct, the halo test. The halo test, y'all remember that from school? The halo test meant, in theory, if you had blood mixed with CSF, you put it onto a gauze pad and you watched it. And in theory, what was going to happen is you're going to see that nice bullseye concentric ring pattern form. Has it actually been shown to be accurate? The answer is yes, in 50% of cases. Otherwise known as you can flip a coin and say heads is CSF, tails is not, and have just as good a success as if you decided to do the halo test. Unfortunately, as we'll show you, there is no really good available way to tell if it's blood mixed with CSF. It's much easier if it's just clear fluid. If it's just clear fluid coming out of the ears post-trauma, it's CSF. It's the only thing that's clear that ought to come out of your ears post-trauma. The tough part is the nose. Because what else is clear that comes out of a screaming 2-year-old's nose? Snot! Good! Well, how do you tell if it's snot, which means you get Kleenex, or CSF, which means you get antibiotics and a potential trip to the operating room? It's called you tested for glucose. Now, you have a couple different ways you can test it for glucose. Number one, you can taste it. Downright gross, not recommended. Number two is y'all just simply dip it. If you dip it, do a Dexy stick, AccuCheck, glucometer, whatever you want to call it, if it tests positive for glucose, it's CSF. Now, why does this not work with blood mixed with CSF? Because blood always has glucose in it, and it's always going to test positive. But you just have clear fluid, that's how you actually tell. How do you remember this? My recommendation is simple. Goobers do not have glucose. Snot does not have sugar. However you want to remember it, if it's clear fluid and it tests positive for glucose, it's CSF, be very hesitant about putting a hose up their nose. Now, why is this a problem? It's called anatomy class. You remember in anatomy class they made you memorize all those incredibly awful things? That you, just like I said, I am going to memorize these for the test. And then I'm going to forget them because I'll never actually use this in real life. Like all the bones in the back of your nose. You remember those? Called the sphenoid bone, the ethmoid bone, the lacrimal bone. Bad memories come flashing back to y'all. You still don't need to know them. All you need to remember is that they're not big bones. Now, when y'all shove an NG tube up their nose, what are you hoping that happens? Is it bounces off those bones and goes where? Down. Very good. Unfortunately, in a small but very well documented percentage of the time, if you've got signs of a basilar skull fracture, it can also go up. And that really looks bad. You want to do a chest x-ray, not a CAT scan, to try to find your endotracheal tube. Therefore, how do you remember this is best described is if you have signs of a basilar skull fracture, bruising around the eyes, bruising behind the ear, clear fluid coming out anywhere, and you're not quite sure what it is, do not shove a hose down their nose. Because who knows where the hose goes? The gold standard, though, currently is rapid sequence oral intubation. And as we'll show you, that means two things. Number one, give them drugs. Why fight with people if you don't need to? And number two, go down the mouth. Now, what do y'all need to know about putting the tube in is actually a couple things. For those who actually put the tube in people, straight blade or curved blade? It depends. Here's the real life story for those who actually put the tube in little children. If you're going to intubate a baby, use a straight blade. If you are going to intubate anybody else, use whatever you want. Because it's just like putting in an IV catheter. Y'all get really good with one kind of IV catheter, and then 2 weeks later the hospital changes and you can't hit squat. The same thing applies with intubation. There's straight blades and curved blades, and with experience you like one versus the other. So again, for those who put the tube in, straight blade for babies. After a baby, use whatever you want. For people who do not intubate, how do you figure out whether it's a straight blade or curved blade? It's simply called ask them. Do you want a straight blade? Do you want a curved blade? They'll tell you. If they say, I don't know, hand them either. Don't worry, they're not going to put the tube in. Now, you're going to hand them a blade. You're also going to have to hand them a tube. Now, when you hand them a tube, how do you figure out what size tube to hand them? Well, there's formulas, right? There's formulas like 16 plus the age divided by 4 divided by the mother's social security number. Do not use it. Does it work? Yes. Do I recommend it? No. Why? You're stressed. And if you're stressed, your brain does not work, right? And asking your brain to do things when it's stressed is not appropriate. Why? Because if you start to figure out some formula, you're going to come up with some incredibly stupid number like 19. Even worse, you're going to somehow find or create a 19 endotracheal tube. Then be honest, guys. Machismo reigns supreme. I can put it in him. This is a problem. Therefore, there's much better ways. Number one, get yourself a chart. My recommendations are available outside on the desk. Either way, there is several charts out there. Most importantly, they fit in your back pocket. They're cheap, and they're made by people that are not stressed. Therefore, when you are stressed, having something that you can pull out of your pocket, pull off your crash card, it says this size tube, this much epi, is a beautiful thing. Is there other ways? Yes. Y'all remember little finger roll? Little finger roll means if you take an endotracheal tube when it's still in the package, remember the bottom of the package is clear? Therefore, you do not have to open every single tube with every single kid. Therefore, if you simply put it next to the kid's, not your little finger, that, according to the book, is the size that's going to fit. And yes, it works. However, you really ought to learn from pediatric ICUs. Because in pediatric ICUs across the country, taped to the head of every bed, we tape what? Not one tube, but 3. We taped one we want, plus one bigger, one smaller. Because sometimes kids don't read the book about what size tube is supposed to fit. Which means if I'm intubating a 2-year-old and a 5.0 tube should fit, I am there, I'm staring at the cords, I am in the zone. And it just doesn't fit. And I can look over at my partner and say, Michelle, do me a favor, hand me a 4.5. The tube is into first time, life is good. So the book says 1, real life says 3, either way put the tube in and be done. Now, take it one step further. You're going to hand them a tube, you're going to hand them a blade. Should you all hand them a tube that has a stylet, otherwise known as a coat hanger, in it? My recommendation is yes. And the rationale is this. When anesthesia taught me how to intubate years back, they said everybody you're going to intubate. From a baby to a big person, put a stylet or a coat hanger in it. And their rationale was simple. You need it, you've got it. The tube is in the first time. You don't need it, you've got it. You're not going to do anything differently. The tube goes in the first time. But you need it. And you're trying to put that big tube in a little tiny hole, and the tube is shaking to the left, shaking to the right, shaking everywhere except for where we want it to go. And the stylet's sitting on the counter, what do you have to do? Exactly. Take the blade out, bag it back up. They're like, why would you possibly do that? Again, the more you bag, the more they barf. Therefore, as a rule, it's just kind of a nice trick to help put your tube in. Now, once you put it in, then the fun begins. Because unless you do anesthesia or a transport or your physician, we do not put the tubes in for the most part. What we do is keep the darn thing in, as we'll talk about in just a minute. Problem involves you now have to suck out the goobers. Why is this a problem? Because you have a choice. You have a choice in suction catheter sizes, right? From 5, 6, 8, 10, 12, 14, 16, 18, and Yankar. Which one fits down a little kid's tube is where the rule of 1 times, 2 times, 3 times comes in. 1 times the size of the tube equals the endo tube. Well, that wasn't hard. You need to have a good way to figure out your endo tube size, because if you need one, you don't have one, any other tube you think about putting in doesn't matter. 2 times the size of the endo tube equals the suction catheter. So if you've got a little kid with a 5.0 tube, what size suction catheter? 5.0 times 2 is 10. Good. So you use a 10, it's going to fit beautifully. Now, if you really want to impress your friends and neighbors, 1 times the size of the tube equals tube. 2 times equals the suction catheter. 2 times also equals the appropriate size NG and Foley that y'all ought to put in. Cool. Now, if you really want to be slick, 1 times the size of the tube equals tube. 2 times equals NG suction Foley. 3 times equals how many centimeters at the lip you tape that endotracheal tube. Which means you're working in the ER. Mom comes in and says those ever so sweet words we love to hear. I've got a push! And indeed, the baby pops out. And you've got a big old 8-pound baby who now is on your cart who needs to get intubated. And you put a 4.0 tube in this baby. What size suction catheter? 8. What size NG? 8. What size Foley? 8. How many centimeters of lip do you tape the tube? 12. Good. Now you've got the right size tubes that are in the right spot, and the Peds ICU is incredibly happy. Therefore, 1 times, 2 times, 3 times really is where it's at.